The cervical sympathetic originate in the ipsilateral hypothalamus, descend through the entire dorsolateral brainstem to the central gray matter of the cervical spine cord up to the level of T1 vertebra. There are three ganglia in cervical part, which lies behind the carotid sheath and longus colli, longus capitis muscle in front, and superior formed by the fusion of upper four cervical ganglia, middle cervical ganglia formed by the fifth and sixth, and inferior cervical ganglia formed by the seventh, eighth cervical ganglia. Sometimes it's called stellate ganglia because of fusion of upper thoracic with inferior cervical ganglia. So the cervical part of sympathetic chain having three ganglia: superior cervical ganglia, middle cervical ganglia, and inferior cervical ganglia. The sympathetic fiber leave the cord via the ventral root, join the sympathetic chain and ascend through the various ganglia to engage plexus on the carotid artery on which they enter the intracranial cavity. So clinically, if you see, there may be clinical presented like enophthalmos, loss of sweating over the face, ptosis of eyelid, and pupilloconstriction. So what are the causes of this? Mainly, if you see, Horner syndrome is there. So, what are the causes of Horner syndrome? The lesion in dorsolateral brainstem, especially vascular lesion in medulla, multiple sclerosis at any level or point and glioma may lead to the Horner syndrome. Lesion in the central cervical cord like syringomyelia, ependymoma, glioma, and traumatic damage. Lesion of T1 root like apical carcinoma of lung, cervical rib, aortic aneurysm, or avulsion of lower brachial plexus is there. Another cause is a lesion of sympathetic chain in the neck, like in the thyroid carcinoma, thyroid surgery, neoplastic lesions, local trauma, accidental surgical damage, or surgical extirpation of various vascular syndrome of the arm. And last, lesion of carotid plexus like carotid artery surgery, carotid artery thrombosis, membranous spasm, local neoplastic destruction of skull base, or involvement of any aneurysm or malignancy in the region of carotid siphon or jugular foramen. You can say any lesion from skull base to T1 level can disturb the cervical sympathetic plexus, which ultimately lead to this Horner syndrome. If you see this, the carotid artery on the right side, on the left, and if you see this is superior cervical ganglia on the right side of your video, and this is situated at the level of skull base from at the level of C1 and C2 vertebra in front of longus colli muscle. And there is middle cervical ganglia, which is also you can see in this picture. After this picture, so inferior, which is stellate ganglia, you can't see in thoracic because it's not in ENT, so that's why it's not recommended. And you can see this is the middle cervical ganglia. So this is all about cervical sympathetic chain.